Good afternoon and welcome, everyone. My name is Paul Helft. I'm the director of the Charles Warren Fairbanks Center for Medical Ethics, and it's a great pleasure to introduce our speaker for today's Fairbanks Lecture in Clinical Ethics. Just a few housekeeping items. The lecture is being recorded and broadcast to IU West, IU Health Arnett, and IU Health Ball Memorial. If you wouldn't mind silencing your pagers and other devices, that would be great. There are phones right out here in the sort of hall closet for anybody who needs a phone. So it's my great pleasure to introduce Dr. Julia Taylor. So Julia is somebody I met when she decided to do our ethics fellowship a few years ago, and I've been continuously impressed by the amazing things that she's been able to do in her young career. She's a pediatrician who got her medical education at the University of South Florida and a residency at the University of Virginia. She's currently a clinical and research fellow in adolescent medicine at the IU School of Medicine and has a long-standing interest in both ethics and reproductive health. She's completing a master's in bioethics, which she'll finish this spring, and is a graduate of our fellowship program from 2 years ago. Her research focuses on adolescent decision-making, and her current projects explore fertility preservation for adolescents with cancer. So join me in welcoming Julia to the podium. Thank you.
Thank you. I really appreciate that introduction, and I'm really delighted to have an opportunity to discuss with you today a topic that I find just intensely compelling and also pretty timely. And now this may be an introduction to the topic for some, but for others, I hope that it's a re-exploration of how and why fertility preservation for adolescents continues to challenge us both ethically and clinically. So for me, it's helpful to ground these discussions in a patient experience and a patient story. So let me introduce you to KW. She's a 14-year-old who's just undergone a left salpingo oophorectomy for a malignant mixed germ cell tumor that arose from her left ovary. Now, her surgery was technically difficult both due to the tumor's size as well as its fragility, and it resulted in spillage of the tumor into her peritoneal cavity and a really prolonged recovery from this operation. Now, early in KW's course, her GYN oncologist spent some time discussing the risks to her fertility because she has one remaining ovary and her chemotherapy would likely affect its functioning. Now, I think it's important that we understand KW, who was a talkative and engaging 14-year-old with a long list of topics on which she had very strong opinions. Those included Facebook, which is only for old people, Taylor Swift, who she loves, chemotherapy, not a fan of, sex before marriage, she plans to wait, and motherhood, which she desires with all of her heart. Now, when her oncologist brought up the possibility of preserving ovarian tissue, KW was all for it. Her mom, however, had reservations. Her mom was concerned about KW surviving her cancer, and she wanted to focus solely on getting treatment started. And so the question that I think underscores why we talk about this topic is who decides? This case illustrates some of the complexities of caring for adolescents in general, but I think it also highlights why fertility preservation focuses our attention on some of the ethical aspects of caring for teenagers. And I think it does this for a number of reasons. First, it involves new reproductive technologies that are often experimental. It also requires an exploration of fertility preferences and parenting intention, which can be a sensitive topic. And for our purposes today, it deals with an adolescent patient whose decision-making capabilities and capacity for understanding are developing and whose preferences may or may not be stable over time. And all of this occurs in the setting of a new cancer diagnosis. I think there are a lot of other interesting ethical questions about fertility as a right or allocation of resources, but we'll have to wait for a different talk. For today, I'd like us to focus on these questions before us. And I think in order to approach these questions with some common ground, it's important for us to start with a little bit of background, including what's available to adolescents today and what we've been doing in terms of research. From this talk, I hope you'll understand what fertility preservation means to adolescents why it's important, and how the conversation can be shaped by adolescents and the parents who care for them so that we provide ethically and developmentally appropriate reproductive care in the setting of a cancer diagnosis. So we'll start with some background information that I think is helpful in understanding the current state of fertility preservation as it's a rapidly developing field. And I think it's important to acknowledge that the conversation we have today is only possible because of advances in both pediatric oncology as well as reproductive health. So I'll touch a little bit on both. And I think we'll also spend a little bit of time reviewing what is available in terms of fertility preservation specifically for adolescents, because it is different from what's available for adults. So I think we first have to acknowledge some of the advances that have been made in the realm of pediatric oncology and their efforts to provide clinical care in a series of clinical trials networks and a focus on outcomes. And this has dramatically increased survival rates. Over the past 40 years, 5-year survival rates have jumped from about 60% to over 80% 5-year survival for all cancers in the pediatric population. And this has led to a relatively new population of adult survivors of a pediatric cancer. And estimates now are that there's greater than 270,000 of these adult survivors of pediatric cancer living in the United States today. And this has allowed us to focus some of our research efforts on the late effects of chemotherapy and radiation. And it has also drawn our attention to the fact that adolescents and young adults fare far worse than their older or younger counterparts being treated for the same cancers. And there's been a renewed interest in adolescents and young adults as a subpopulation within oncology that have complex needs and require comprehensive care, including reproductive and sexual health care within their treatment and afterwards. At the same time, there has been a national and international focus on women's health and reproductive health, and a reframing of fertility as a marker of health, and infertility not as an unfortunate event, but rather as a disease or disability. And this has paved the way for new interventions that really focus on the prevention, detection, and treatment of infertility, and specifically technologies that are available for the preservation of fertility for later use. For better or for worse, this has also been helpful in starting a national dialogue about women's health and choices and what employers and insurance companies can reasonably provide. I think more to our point, it's also allowed us to discuss about the stigma associated with infertility and subfertility. We know that cancer survivors report infertility as one of the most distressing late effects of their cancer treatment. And while we understand the theoretical risks of damaging rapidly dividing fragile cells, including those in the reproductive system with our chemotherapies and our radiation, it's incredibly difficult to study. And I think that's in large part why this ranges in terms of our projections of infertility risk. We typically use proxy measures, especially for young women, be that hormonal levels or menstrual cycles. And so you get estimates that range from 15 to 90% risk of infertility. The other reason that this ranges is because we're just learning what characteristics place young people at a higher or lower risk of infertility. And some of these characteristics are listed here. We know that having prepubertal ovaries and testes is actually protective. There's something about teenagers being in puberty, having their HPG or hypothalamic pituitary gonadal axis active that places them in a more vulnerable state for the effects of chemo and radiation. Men are also more sensitive to the effects. We think that this is due because the testes and sperm seem to be a little bit more sensitive to chemotherapy and radiation. And chemotherapies themselves differ in their effect on fertility, with alkylating agents being the most gonadotoxic in a dose-dependent manner. Radiation also, depending on the site and the dose, can be gonadotoxic, and these doses are listed in grays, and that's all it takes to kill off an oocyte or sperm. And to put it in perspective, a typical radiation dose can range anywhere from 20 to 80 grays or 1 to 2 grays per day for a 5-day per week treatment course. So it doesn't take much radiation to reach gonadic toxic levels. In addition to what we know about infertility and subfertility, I'd also like to spend a little bit of time now on what options are available to prevent fertility complications. And since they vary by gender, I've broken them down, and we'll talk about the female options first. Now, I don't think we need to go into each option in great detail, but I think it is important to understand the treatments that are available to adolescents and their limitations. And I also think it's important to understand which ones are still considered experimental. Now, everything up here with a black star is considered experimental. I have oocyte freezing designated by a white star because when I originally started researching this topic, it was considered experimental. But in 2013, the ASCO guidelines reported that there was enough evidence to make this clinically available to women. And now whether these individual options are appropriate for any given patient depends on pubertal status, relationship status, illness and cancer type, and the acceptability of treatment delay. Embryo banking, for example, or emergency IVF as it is sometimes called, requires about a 2 to 5 week delay in treatment, and it also requires sperm from either a donor or a male partner. And so this is not generally applicable to teens and certainly not available for prepubertal children. Oocyte freezing, on the other hand, overcomes the need for a partner or sperm donor, but the procedure still potentially requires a delay in treatment as oocytes are harvested 10 to 14 days after menses. It has had great success, though, with greater than 500 live births from frozen oocytes, although not all of those have been in cancer patients. Ovarian tissue freezing involves the removal, sectioning, and freezing of part of an ovary. The ovarian strips can then be transplanted later back to the same patient to restore hormonal function or used for IVF. So this does not require any delay in treatment and is available to adolescents. Now, there have been 2 reports of live births from ovarian tissue transplantation back into a cancer patient. I think it's also important here to note that aside from hereditary genetic syndromes or exposure to chemotherapy in utero, none of these have been associated with an increased risk of cancer or congenital malformations in the offspring of cancer survivors. Now, during treatment, there are different options that are open to teenagers, and gonadal shielding takes place when there's radiation to limit the exposure, and the ovarian transposition can occur prior to radiation to remove the ovaries from the expected field of radiation. Hormonal ovarian suppression with the use of Gnrh agonists is controversial and the jury is still out. This theoretically makes sense if we know that prepubertal or quiescent ovaries are protected, but in studies we've had mixed results, and there are ongoing randomized controlled trials that we have yet to see the outcomes of. And so I think it's important to know that there are options available after cancer treatment, but I'm not going to spend time on this today since my focus is on fertility preservation. So for adolescent women, the only non-experimental option is oocyte freezing, and the only option that can be performed before treatment start, but without any treatment delay, is ovarian tissue freezing, which is experimental. For young men, there are some similarities in what options are available. There are also some of the same limitations in terms of pubertal status and the experimental nature of some of the options. But sperm banking is accepted as standard of care for any male capable of ejaculation. Experimental procedures here are again indicated by a black star, and you'll see that hormonal suppression is actually crossed out from young men because there is actually enough data that demonstrated no benefit to this therapy, so it's been removed from the options for young men. Now, in terms of prior to therapy, in addition to sperm banking, experimental therapies include obtaining sperm from any other method other than masturbation, which could be electrostimulation under anesthesia or testicular sperm aspiration. Testicular tissue freezing, which is similar to the ovarian tissue freezing in young women, is also experimental and potentially would be the only option available to prepubertal males. You can see there that there are also some gonadal shielding options during radiation, throughout treatment, and then afterwards, young men and women share similar options for family building. Since there are a number of available technologies that have demonstrated the potential for use in adolescents and in children, I think it's important to know that there are several professional bodies who have developed recommendations or guidelines for fertility preservation in children and adolescents, and I'll go through a few of those. I've already referenced the ASCO, or American Society of Clinical Oncology guidelines, because they have the most recent recommendations. They updated their recommendations in 2013. They recategorized oocyte freezing as clinically available and no longer experimental. They also recommended against the use of hormonal suppression in young men. They specifically talk about the early discussions about fertility preservation, regardless of age, and referral for experimental protocols for both children and adolescents. Now, the American Academy of Pediatric Committee on Bioethics supports the use of sperm banking for young men as a proven fertility preservation method and highlights the experimental nature of those that are available for young women. The American Society for Reproductive Medicine also specifically mentions children and potentially or presumably lumps adolescents in there as well, and focuses on the need for patient assent and the calculation of a net benefit to the patient, also recognizing the importance that any approach we take to this topic be ethically balanced and thoughtful, especially when it occurs with young people. So, given that we have the technology to discuss fertility preservation, granted some of which are experimental in nature, I think that the question is, how do we discuss these technologies with families in a manner that respects the young person's developing autonomy, acknowledges the complexity of the situation and the sensitivity of the topic, while balancing the roles of both parents and providers in what is ostensibly a shared decision-making process. And for that, we turn to the literature. Some of the problems I have with the literature as it stands now and with the recommendations that we just went through is that it lumps children and adolescents into one group, and it may not come as a surprise that I think that that is a mistake for a number of reasons. I think the complexity of the question is not more or less with an adolescent, but I think it certainly is different. Lumping adolescents fails to acknowledge the difference in ethical considerations between decisions that parents make for a 5-year-old versus the decisions that parents make with a 16-year-old. Who demonstrates some degree of capacity and who is granted, actually, in most states, some degree of autonomy in making decisions about reproductive health choices. So while a discussion with a prepubertal child's family about late effects and fertility preservation might be primarily directed towards the parent, a conversation with a 16-year-old and their family may require a provider to devote more time addressing the adolescent's specific concerns, and there may be agreement or disagreement between the parent and the adolescent, as well as additional conversations that happen outside of the clinic setting between the parent and the young person. Not to mention the added complexity of an age range of 12 to 17, which encompasses a wide range of normally developing adolescents with varying degrees of vulnerability, capacity, autonomy, and health literacy. They will each be at a different stage of sexual maturity, with different understandings of their own sexual identity and different comfort levels with discussions about reproduction or masturbation. They will also be developing their own voice and autonomy within their family unit and within the larger community. They will differ in their decision-making capabilities and their willingness to engage in medical decisions. And they'll also have varying degrees of future orientation and have devoted different amounts of time to thinking about themselves as parents. And ideally, since this conversation with adolescents and their parents would be informed by evidence, we went to the literature with the goal of systematically identifying, analyzing, and synthesizing studies that explored specifically the perspectives of and experiences and preferences of adolescents, their parents, and the providers with regards to fertility preservations. We included studies that focused only on adolescents, and it had at least one question related to fertility preservation. And while we screened over 1,000 studies, ultimately we found only 17 unique studies and 3 sets of linked articles that addressed adolescent-specific concerns. Now, these studies included both qualitative and quantitative data, and they used different methodologies. They drew their samples from both survivors and patients undergoing treatment, and they were approached by researchers with varying backgrounds and theoretical underpinnings, which required us to carefully consider how we were going to incorporate such heterogeneous data. Since it was clear from the beginning that a meta-analytical approach was basically impossible, we looked for other approaches. And while there's a growing understanding of the importance of qualitative research and quantitative syntheses, and Cochrane even has a working group on this, there's no consensus on how to deal with this type of data. So in reviewing some of the available methodologies, we chose to adapt a narrative synthesis approach because it primarily focuses on textual data and words in its synthesis. And while it was originally intended to influence health policy, it adapted well for our uses of informing clinical practice. So we evaluated each study for quality. We included both high and low quality studies in order to maintain the most breadth and depth in terms of our analysis. And a narrative synthesis, its approach includes 3 primary steps: the preliminary synthesis, the exploration of relationships, and assessing the product for robustness, which occurs during the quality analysis and also later on. And so what I've included in the next couple of slides are the themes and concepts that we uncovered in our analysis. Now, fertility and trust is a concept that we came up with, and we defined it as an obligation of both providers and parents to recognize the long-term importance of fertility and to act in a manner that supports adolescents developing autonomy with a focus on their future self-determination in terms of reproductive choices. And we chose the term in trust because it refers to one party managing the assets for the benefit of another. And fertility was seen as a long-term issue that was influenced by short-term decisions, and thus it was necessary for adolescents to rely heavily on their parents and providers around this decision. Some of the sub-themes that informed this topic for us were the consistent report by all parties that fertility preservation was used as a means to keep future options open. It wasn't always entirely tied to a notion that that young person had about their future, but simply retaining the same options that they came into cancer treatment with when they left cancer treatment. There was also a strong feeling on the part of providers and parents that fertility affects the quality of life, the relationship milestones, and other developmental achievements that young people go on to after cancer. There was also a sense from both survivors and their parents that fertility became more important over time, that initially survival was their focus, but as their young person got better, fertility and some of these other late effects became to the forefront. And now there were several teens and their parents who acknowledged a discrete parenting intention. So fertility preservation was sometimes linked to a knowledge by that young person that they had always intended to be a parent. And lastly, something that I think surprised us is that parents and young people actually gain hope from conversations of fertility preservation. To them, it felt as though this was a message that their young person was expected to survive, and so they should begin planning for the future. And I think it's important because we sometimes focus on how overwhelming fertility preservation discussions are and not on the positive benefits that can happen. Additionally, many of the studies we included provided findings that were helpful in understanding why this is such a challenging discussion and challenging decision. Specifically, the sensitive nature of fertility conversations was referred to by both providers and by young people, frequently calling it an embarrassing situation. It was also noted that the timing is difficult. Since this happens before treatment in a lot of cases, there was the complexity of being a diagnosis of cancer, starting treatment, and the overwhelming sense that parents and adolescents already had too much to deal with on their plate. There was also varying degrees of parental desire to control information or provider to control information. And I think because these sometimes conflicted, that made these discussions even more challenging. There was also the sense that there wasn't a lot of options for young women, which certainly complicates things further. And then there were definitely provider variabilities or limitations that affected participants' comfort level with discussions of fertility preservation. Several other studies focused on provider perspectives, and actually knowledge about fertility preservation is highly variable depending on the provider type or the specific question being asked. But despite variabilities in knowledge, providers were on the whole incredibly supportive of fertility preservations despite their low referral rates, especially for young women. So there was definitely some discrepancies in providers' idea that fertility is incredibly important to the long-term outcomes of young people versus their actual practice. Other studies contributed data that reported on differences between adolescent and parents' expectations about fertility information and the actual content and context of the information that they received. Timing again featured prominently, with some families reporting that it was not until after the chance had passed to do anything to preserve fertility that they learned about fertility complications. Additionally, several studies reported on the acceptability for families of experimental therapies. Although it's not clear how often these are discussed with families, none of our studies specifically asked families to recall that information. What I think was clear from this review is that there were certainly areas we could improve upon in our delivery of fertility-related information to adolescents, but there were certainly limitations in the available studies. Most of these studies were further out from diagnosis, with only 3 being within 2 years of diagnosis. And many of the studies did not ask specifically about how families would like to receive information. There was also relatively limited information on how parents and young people might navigate this decision and come to a consensus. So with that background, we undertook a qualitative exploration of some of these topics with adolescents and their parents here at Riley. With our goals to describe the optimal content, method, and timing of fertility preservation information, while also exploring the decisions and how they're made in the family setting. Our goal was to recruit 20 dyads of parents and adolescents, and our inclusion criteria focused on those who would be at highest risk of fertility complications, mostly from their exposure to high-dose alkylating agents, and to be within 2 years of diagnosis, because we felt that it was important to understand what happened immediately following diagnosis in terms of their views on fertility preservation. We approached this with an adapted grounded theory and iterative approach, and since this is an ongoing study, what I'm presenting here is preliminary data. So far, we have completed a total of 9 interviews, 5 adolescents and 4 parents, all of whom have interestingly been mothers so far. The participants have had different diagnoses, but they've all been about 17 to 18 years of age. And in the time remaining, what I'd like to do is explore some of what has emerged so far from this study. So far, fertility preservation was offered to both male participants. One chose to bank sperm, one did not, but no fertility preservation options were offered to either female adolescent. It's clear that there's an emotional response when it comes to fertility preservation. Finding out about fertility complications, whether it was read about in chemotherapy packets or discussed with the provider, brought forth some distress in many of the adolescents. And these adolescents had considered their desire to be parents in the future and actually ranked that as an important part of their life. For example, one young woman, age 17, recalled I'm pretty concerned about it because I remember getting the sheet with all my chemo on it and all the side effects. They said that I wouldn't be able to have kids when I'm older. And that really concerned me because that's a big part of my life. I don't really see myself as not having kids. Or a young man age 17 put it this way: I don't know exactly how to say it. It's kind of upsetting in a way because in the future you maybe want kids, but they told me you could store for the future, so we tried to do that. Parents also commented on the emotional response of their teenagers to fertility information, with a mom of a 17-year-old female remembering, and in the car on the way home, she was like, "Mom, can I see that?" So I threw it, the chemotherapy consent form, in the back seat, and she started to cry and was like, oh my gosh, look, it can cause me to be sterile. It really upset her. Now, regardless of the emotional components, decisions for males were actually experienced as relatively straightforward, whether they chose to pursue or forgo fertility preservation, with one young man commenting, seemed like it was just a normal conversation, like one he has to talk about every time he talks about a treatment. So it didn't seem anything abnormal and wasn't a change in attitude from what he's normally like. And another young man, I just kind of said, we might as well just do it. In interviewing parents, it's clear that parents also perceive fertility information as really important, and they support the provision of timely and accurate information to young people by providers. From the mother of one 17-year-old. We knew it would destroy most anything in his body, and it was brought to our attention that it could destroy his sperm, and so we thought we need to get something preserved. And another mother identifies how this information would ideally be provided. I think that if that would have been done in a different manner, maybe it wouldn't have been so shocking to her. Teaching of all that stuff needs to be done before the start of chemo. It should have been done prior. And yet another parent perspective. Not that maybe it would have changed her outcome, but had we had more information available about what type of preservation was available, we may have made some different choices. And these interviews so far also emphasize the role that adolescents and parents would like providers to play. A young woman recalls, I guess in a way, my doctor didn't really talk at all about fertility, except when we read about the side effects. And moms speak to the importance of the role that providers play as well. The doctor, he brought it up. If he would want children, that would be the thing to do, or the role that they wish the provider would have played. I think that if she had just heard that from the doctor and had a chance to voice her questions to a professional. And finally, I would hope that if the doctors had some concern, that they would have told us up front and made a bigger deal about it if infertility was definitely an issue, of saying we advise this, or this has been a huge problem in the past with this kind of treatment. And so we begin to see the difference between the role that providers actually play and the role that parents and adolescents expect them to play when it comes to discussing fertility preservation. And so really, in summary, providing fertility preservations is an ethically complicated topic, and one that forces us to examine the roles that each party plays or should play in the information sharing and decision-making process. We have to consider how adolescents whose autonomy and decision-making skills, as well as parenting preferences, are evolving, should be engaged and informed during this process. We also must examine what role parents play in providing and controlling information and decisions. And maybe most importantly, the role that providers play in disclosing or failing to disclose information about fertility-related complications or fertility preservation options. And so I hope I have at least convinced you that any approach that we utilize in discussing fertility preservation should be empirically informed and developmentally appropriate for adolescents, who are distinctly different from children and adults, especially when it comes to fertility preservation. I think future areas of research that could provide even more information about how we deal with this topic should approach this with different models of care, including comprehensive health care with sexual and reproductive health integrated into cancer care early on, or adapting an adult model of fertility navigators who have specialized expertise in discussing the topic to aid in providing timely and developmentally appropriate information to adolescents and their parents, and then implementing these models with a focus on both patient and provider outcomes while recognizing the unique challenges and needs of adolescents and their parents. Thank you very much, and I'm happy to take any questions. Yes.
First question. I wondered if you could talk about how you think you might best, or a provider might best address a parent who wants to inhibit your ability to talk directly to an adolescent about the issues. So if there are strong preferences about whatever, talking about fertility, sexuality, or other things, make them feel as if they really don't want you engaging in that, how would you best manage that situation?
I think each situation is going to be unique, and I think actually the problem is that in a lot of situations we haven't asked what the preference is and haven't explored that, so don't know. I think if a parent had a strong preference, I would ask to talk to them alone and explore that further. In some cases, there's information there that you really need to get to the bottom of why they have a reluctance in these issues or why they don't have an open communication style with their young person. So I'm not sure that I can answer that with broad brush strokes, but I think talking to that, taking the time to sit that parent down and exploring what their reservations are, because it's pretty clear that young people feel like this is information that they want and need, and so expressing that to that parent and seeing if you could come to an agreement about how to approach that young person would be an ideal situation. Yes.
I think a lot of people would make the same arguments. Long-term, late effects counseling should be involved from the beginning. Maybe palliative care should be involved from the beginning. Going through these papers, did any centers identify risk with sort of overstimulating the families too much information too early in such a difficult, traumatic time at diagnosis?
Right. So that's definitely one of the things that came out of the review, is that providers perceive that time as overwhelming, that they're just inundating families with information, that there's no way that they're going to be able to comprehend it. And parents actually acknowledge that on the back end too. They say, that was a really difficult time, but I still wanted the information. So I don't know that there's a perfect way to do it. One of these interviews that I've conducted recently, mom specifically said, I know you knew my daughter was coming in because you said you had a conference about her care. I wish we had gotten something in the mail to prepare us for the visit that we had. And so, yes, it's definitely a vulnerable time for these young people and for their parents. And I think the perception of providers that they're burdening the families with yet another thing is a real one. But I think you also hear loud and clear from the families that even if it seems burdensome at the time, they're thankful for having the information and the opportunity to discuss things like fertility and late effects. Yes. So not generally. So I have sort of a breakdown of price, and I'm happy to pull that up. So things like ovarian transposition can be done and sometimes covered by insurance procedures or insurance payers. Things like ovarian tissue harvesting are sometimes paid for. So I have some of these up here. So like the ovarian tissue freezing as an example. This is the general guesstimates for prices. Sometimes that can be incorporated if you're participating in a research study into those, or you'll get a discount on it. In the adult world, part of the role of the fertility navigator is to discuss with the insurance company where they might provide some coverage or where they might cover part of the fees associated with it. But you're right, payment is a huge issue. I think these numbers seem staggering until you also look at what actually it costs in terms of IVF after cancer, or when you think about gestational surrogacy or adoption. So I think that the figures are startling unless you put them in context of what it also costs after cancer to potentially use some of these other assisted reproductive technologies. But it's a good question. Even sperm banking, which is clinically sort of available to all young men, is not typically covered in terms of storage fees. Yes. Mm. Right. So I think you're right. In terms of young men, it's pretty straightforward. Sperm banking is there. If you're talking about prepubertal men or young men, that the availability of like testicular tissue sampling and freezing is really small and only in large academic research settings. In terms of ovarian tissue freezing, which would be sort of maybe you might characterize as one of the easier options for young women, it's also still available only in large academic research centers. So if you were to have a patient here at Riley at this current time, there is not an IRB protocol in place, although there is one being worked on. And we have a pediatric and adolescent gynecology with the capabilities and the training for doing this. But if you had a family who was really interested, places as close as Cincinnati do in fact do these procedures and have a pretty functional fertility preservation program for adolescents. Things like the hormonal ovarian suppression is actually what KW and her mom ultimately agreed upon as a method that they could both support. But I think you have to be careful about that because it is still experimental and really should be done in one of these randomized controlled trials where we can find outcomes. But I think that fertility preservation is sort of gaining a foothold. There are more pediatric and adolescent gynecologists or urologists who are trained in this. So hopefully you'll be seeing it in more centers soon. Did that answer your question? Okay. Yes.
You know, it's not even as easy as it sounds for young men.
Mm-hmm.
We have several patients which for a while I had to literally Google to figure out who was doing it here because the coverage had gone up and down. And there's only one private clinic that I know of on the north side who does it for young men. And the way we do it is we give them the number of the clinic.
Mm-hmm.
And I've had several mothers come and tell me that the staff was very insensitive. They really did not give us a lot of,
Support.
support.
Mm-hmm.
So,
yeah, I think that I think that that's so true. And I don't mean to leave young men out of the conversation because I think that the same sort of support and information that they need, because similarly, one young man I interviewed didn't understand how the sperm was going to be produced. Like he just didn't get it. The provider didn't pick up that he didn't get it. And so mom had to explain to him like what they were going to do at the sperm banking center. And you're right that sperm banking centers are not used to adolescent men who are there with a cancer diagnosis. That is not their forte. And so this is, again, one of those instances where certain centers have put into place these quality improvement projects where they've brought in someone to go through this in detail with young men and shown that their rates of acceptance and their rates of actually producing usable sperm has gone up. One of the things that really tanks the ability to get a good sperm bank option for young men is their anxiety around it. And so they can't produce something usable in that situation. So I agree that there are areas there where it would be helpful just to have someone where this was their focus. I think that oncologists have a lot on their plate, and I think that it would be helpful to have a separate space to talk about things like fertility preservation or sperm banking. Yes. Mm-hmm. Yes. So not with ovarian tissue. So if you had a running protocol and a surgeon who was capable of doing it, it can be done at the time of port placement. So a surgery they are already undergoing an anesthesia that they've already accepted the risks for. It's a simple procedure that they do laparoscopically, not much recovery time, no need to delay treatment except the delay that would already go into getting a port placed. But great question. I think a lot of people are concerned about that, especially with pediatric cancer. Sometimes we catch them late, and sometimes we need to get them enrolled in the protocol or their treatment. So definitely. Yes, she is available, but we don't have an IRB protocol approved for her yet, mostly because similar to the limitations for young men, there is not the established lab to do the cryopreservation in processing of the samples yet. So she has to work on those pieces, but that is actively being pursued as an avenue for young women here. Yes. Yeah, so that's what they use in the adult model as a fertility navigator who, when the oncologist mentions the fertility, that's all they have to do. The oncologist sort of calls the fertility navigator who goes through insurance questions, goes through the different possibilities that are available to that person after consulting with the oncologist and sort of handholds through the rest of the way. So there isn't that available now. I agree that if we're going to expand the services that we're offering in terms of fertility preservation, that has to be a key piece, because you're right, in sort of answering those questions, someone who's familiar with the procedures, either the surgeon themselves or someone who's just well versed in it, I think would be really important. So I think that has to be considered as we're expanding those options. Yes.
I don't know whether it still exists, but they used to do telephone navigation.
Yes.
Called Fertility in Northwestern.
Yes.
So a few years back, I used to give them their telephone numbers and say, go and call them, and they would walk you through. I don't know how.
So they even have an app now. Yes. So I Save Fertility, Oncofertility Consortium out of Northwestern has done a lot of the research in terms of the technical abilities to preserve fertility. They've also sort of been the ones to pioneer this fertility navigator model. And so, yes, for highly motivated families who are not in an institution where they provide a lot of options, you can call Northwestern and they will identify a center near you and try to help you navigate that process. So yes, they do have sort of an outreach, and they have an app that's helpful for providers. So if you don't have a person to go to, there's actually an app that can go through some of the things that are the specific details about the different procedures. And then they also have, yes, a family website that explains and actually has a separate website for children and adolescents in that regard. Yes. So we do have some of that information compiled, because one of the concerns with my study was that if I was going to ask these questions, that people might have more information. So we do have sort of a family packet that's available that I can give out to patients, and that we are in the process of having made available at the family library at Riley. Yes. Mm-hmm.
Is that kosher/allowed? Is it happening? And if it's not happening, how do we support our patients when they can't?
Yeah, I think that that's a good question. I can't speak to what the insurance companies think is kosher or not. I know that that's how some of these things like gonadal shielding or transposition are paid for, because they're just billed within the diagnosis of cancer. The Live Strong Foundation actually has some financial support that they have available and make available to families. So there are some sort of charitable means for paying for some of this. I think ultimately it takes advocacy at the insurance level for coverage for this. Again, it's an iatrogenically, produced state of infertility, and so you could argue that you cover their late effect cardiac myopathy or their late effect lung disease. So this would be really important to cover as well. So I think ultimately that takes some advocacy, but I don't know how they do it specifically at Northwestern. I know they have someone who focuses their attention on working with insurance companies, but I don't know where that stands right now. Yes. Right. 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 Mhm. Right. Great. No, I really appreciate it. And I think, yes, and I think that your point again just raises the sort of minute details that it's hard for people who are outside of the world of fertility preservation to be able to discuss with patients and their parents. So I think that like early referrals for patients who are interested to talk with someone who is capable of doing these procedures is really important. Thank you. Yes. Of oocytes? Yeah, so I didn't go into much detail. So you could have an ovary sample with immature oocytes that are then matured in vivo and then used later for IVF. And so that has been explored. And I think that in cancer patients, there's a total of 19 or so live births from either frozen oocytes or matured frozen oocytes. So much more limited data in that. And I think that again raises the complexity about how you talk to patients and families about the outcomes of some of these. They're still so new that we don't have much data to see what the outcomes are of ovarian tissue freezing. We think that it's really hopeful and that it'll be great, or that the in vitro maturation of oocytes is something that is worthwhile and that we're capable of doing, but the outcome data is not great. Which is why there's more research needed, right? So, yes.
Can you say more about the objection of parents to this? If a parent objects, is that the final word?
Yeah. So in reviewing the literature, it depends on where you're from. So it was really interesting in the Netherlands, providers had no qualms about overriding parents. And they felt that fertility was such an important issue and was going to be such an important issue for this young person that despite the parents' objections, they would find a way to talk to that young person alone. They also had more protocols in place for sperm banking and that sort of thing. So it may have been something that was just sort of better integrated into their practice. In the United States, I think that most of the data suggested that providers tended to defer to parents if they had those conversations. And so I think that it depends in large part about the style of your practitioner, how they're going to choose to approach that. I think what's probably more obvious from the data available for young women is that the conversations just aren't happening. So we don't know how parents respond to it in a lot of ways. So there's this sort of failure to disclose or omission of some of the information about fertility preservation because it is such a complicated topic and there is such a lack of choices and options that we don't even know how parents perceive it. I think in large part, parents are overwhelmingly supportive. There were very few that objected to the topic itself. Some of them objected to how it was approached, that their young person was either too sick to hear that information at that time, or that they didn't like the idea of the young person hearing the information without them present. And I think that again depends widely on the patient, where they are developmentally, and the parent and their comfort level with those. So parents objected more often to the fact that they felt that their young person was just too fragile to get the information at the time, or that they were excluded from the conversation and not, they didn't have a problem with the idea of fertility just being discussed in and of itself. Does that sort of answer your question? Okay. Anything else? Well, thank you. I really appreciate the conversation about this topic. Thank you.